All right, welcome everybody to another Sydney Neonatal webinar. It is a great pleasure to introduce to you Professor Robert Christensen. I met Bob as he introduced himself to me this year in the BINS Neonatal Conference in Thailand, which I also would highly recommend as one of the conference to attend. He's a professor in pediatrics and intermountain healthcare, a healthcare complex, and chief of division of neonatology at the University of Utah. And his work, I think we have all read his work. It involves blood problems in newborn infants, including all the specific aspects of it. He's written many, many papers, and today he's going to take us to the topic of neonatal anemia. All right, Bob, over to you.
Thank you very much, Kurt. Thank you for inviting me. Thanks to each of you for tuning in. My goal in this presentation is to give you something that you can use today or tomorrow or whenever you're on service. Most of what I tell you will be, I hope, immediately available and useful to you. Some of it, obviously, you're doing already. But it's my goal to be able to teach you something that you'll find useful in your practice of neonatology. Toward the end, I'm going to talk about a little bit of the research that we're doing here and at other places where we're collaborating. And maybe that will just be forward-looking and not something that you can do immediately, but at least you'll know that it's on the horizon. You see this first slide. This is a picture of Dr. Max Wintrobe, who was the first instructor that I had in the field of hematology. I did two fellowships, one in neonatology and one in hematology, and kind of did those simultaneously. And Dr. Wintrobe is in some circles known as the father of clinical hematology. And did a lot of early pioneering work on anemia. And so I'm going to mention him several times throughout the presentation. The topic that I've chosen is, as Kurt said, anemia, but it's actually 5 different topics that I think are relevant to neonatal hematology that are relatively new and I hope will be stimulating to you. As far as disclosures go, I don't have any financial conflicts of interest, and I'm not going to try and talk you into any off-label medication use. This in the background is the University of Utah School of Medicine campus in the foothills of the Wasatch Mountains in northern Utah. My objectives for this presentation is to set the stage for you to be able to give an evidence-based definition of anemia in a neonate. Second, to describe how nucleated red blood cells can help orient clinicians to the anemic neonate and also help orient you to neonates who have encephalopathy as a presenting finding. Third, we're going to turn to platelets for a bit and explain the term platelet transfusion refractoriness in thrombocytopenic neonates and what we can learn from that and how to avoid it and how to treat it if it happens. Fourth, we're going to talk about blood donors for NICU transfusions and the effect of blood donor sex and age on outcomes of neonatal transfusion recipients. And then we'll end with talking about low titer type O whole blood for acute massive blood loss in neonates and perinatal patients, women as well. And end with something about using otherwise discarded term healthy umbilical cord blood and making from it transfusion products for our extremely low gestational age neonates. Okay, we'll start with a definition of anemia. Again, this is Dr. Wintrobe. He was recruited to the University of Utah from Hopkins in 1943, when the university here went from a 2-year to a 4-year medical school. At that time, the School of Medicine was located in the Salt Lake County Hospital, which you see here with the flag in front. It is a building that no longer exists. But when Dr. Wintrobe came, he noticed that behind this building, back here in the parking lot, was an old white shed. It was the only facility on that block that he could use for his hematology research lab. And so he set up that shed, and for the next 22 years, it became known as Dr. Wintrobe's bloodshed. And here is his technician, Jackie, going into the bloodshed. And here's Dr. Wintrobe explaining some elements of the physical examination to some students. This in 1965 is where that hospital moved. This is in the foothills behind the main University of Utah campus. And you would hardly be able to find it here. This is the old building. Now, amidst all the various hospitals and facilities of the University of Utah Health Sciences campus today. When Dr. Wintrobe came to Utah, he had just published a paper describing a very interesting and novel test called the hematocrit. The next year, after publishing this treatise on what the hematocrit is and how to measure it and what it means, he published the study on the red cell indices, that is the mean corpuscular volume, mean corpuscular hemoglobin, and mean corpuscular hemoglobin concentrations. After determining what these were and how to best measure them, he then sought to determine what normal values were and what values were too high and which were too low, and what that meant when they were abnormal. And so he asked, how are we going to do this? We need to draw blood on large numbers of healthy adult volunteers. Well, every day on this is a question. Where do we find large numbers of healthy volunteers to have blood counts perform in order to know what's normal and what's abnormal? Well, every day on his way from his home to the hospital, he would pass this old Gothic building on 21st South in Salt Lake City, which was the Utah State Penitentiary. And I never did hear him say this, but I imagine one day he passed this building and imagined this sign on the wall, healthy volunteers inside. And he and his fellows quickly struck up a friendship with the warden of the prison. And over the next decades, had a good relationship with a lot of prisoners who voluntarily gave blood counts for his studies. Well, a few decades later, when I became a fellow in that department, I wanted to focus on neonatal hematology, something that none of the previous fellows had done. And I asked, can we do what Dr. Wintrobe did initially with neonates? And where in the world are we going to get normal ranges to establish normal things for even like hematocrit and red cell indices in babies? Well, we couldn't go back to the penitentiary because that had been torn down, and actually there weren't that many babies there anyway. And so what we decided to do is take a different approach and give up the idea of ever having normal ranges for blood studies in neonates, because we're never going to have large numbers of healthy babies volunteer to have their blood drawn. Rather, we'll go to reference intervals, which by definition is, we do this by taking very large numbers of CBCs that were obtained clinically, they were ordered by a physician, but the baby was later turned out not to have the problem that it was thought to have, did not have sepsis, for instance, or had very minimal pathology or no pathology related to the CBC item under study. And then over the years, collected lots of these values, curated in that fashion, and organized according to percentiles. That is, less than the first percentile, first to the fifth, 95th, greater than the 95th. This is what it looks like today. This is a reference interval on hemoglobin on the day of birth, according to gestational age in weeks. Here you see hemoglobin. Here you see gestational age in weeks. And here you see the lines representing the first percentile, the 5th, the 50th, and the 95th percentile. This reference interval is based on over 360,000 neonates curated for the absence of pathology as best we could. And if you want to find this, it's in the June 2023 NEO reviews. Now, some people like to use this kind of information as a chart. So you have a baby that's 30 weeks gestation with a hemoglobin of 10. You see that's less than the first percentile. Others would rather see this as tabular data, and therefore we do it both ways. This is tabular data for the same information for diagnosing anemia on the day of birth according to gestational age. But here you look at the column, gestational age, 30 weeks, and then as you look over, you see the 5th percentile hemoglobin value, the 1st percentile hemoglobin value, and the 5th and 1st percentile hematocrit values. We have the same basic setup for other elements of the CBC. We have the hemoglobin, late preterm and term infants in the first month, the hematocrit, late preterm and term infants the first month, the hemoglobin of preterm babies first month, hematocrit, same. Then we have hourly over the first 4 hours after birth, depending on gestational age, because of fluid shifts change the hematocrit. But what are the patterns? We also have this for some of the newer metrics, such as reticulocyte hemoglobin as an excellent marker of iron deficiency over the first 90 days. For Dr. Wintrob's initial measurements of MCV and MCHC on the day of birth, and for other measures that I like called the micro R and hypo HE during the first 90 days after birth. You can find those in this NEO Reviews article if you wish. Now, one thing Dr. Wintrob noticed as he studied the hematocrits of men and women in Salt Lake City is that men typically have higher hematocrits than women do. So here you see a typical American man and a typical American woman. And when he has his CBC drawn, the hemoglobins and hematocrits have to be compared with an entirely different chart of normals compared to when Hillary gets hers drawn. My question was, do we need 2 charts for babies? Do we need a baby boy and a baby girl chart? Are they different like older children and adult men and women have different hemoglobins? And so to answer this, we matched over 20,000 male and with over 20,000 female neonates, matched for gestational age and date and so forth, and found no difference. And so I think that just was, it goes to show that gender doesn't make much difference, at least in certain CBC parameters. Another thing Dr. Wintrob discovered was the standard definition of anemia was altitude dependent. He had come from Baltimore, near sea level, to Salt Lake City, nearly a mile above sea level. And at higher altitudes where there's not as much oxygen, people acclimate to needing a higher hematocrit to transport adequate oxygen to their tissues. Whereas in Death Valley, there's lots of oxygen and people get along with a considerably lower hematocrit. So in assessing what hematocrit defines anemia, the altitude at which the patient lives is relevant. And my question is, what about babies? Do we need one set of normal values for Denver, Albuquerque, and Salt Lake City, and another set for the coastal cities? And so we looked at hematocrit ranges of neonates in Salt Lake City versus Los Angeles, pairing them, and they were the same. It didn't matter at all. And so I think for neonates at birth, altitude is not relevant like it is for hematocrit in older children or adults. And it may be that in utero, the altitude or the oxygen tension is relatively the same. So these twins in utero, they don't know if they're a mile high in Park City, Utah, or if they're at Disney World. They just know that there's plenty of oxygen for both of them, and they're having a lot of fun in there. Now, this is a study where we employed that reference range to look at babies who were, by this definition, anemic at birth. We asked, how many have we gotten? Who are they? What's the cause of their anemia? This is from Journal of Pediatrics in 2022. So again, you see this same reference interval, gestational age, hemoglobin, and the lines, first, fifth, 50th, 95th percentile. And in this particular study, we looked for babies who had an initial hemoglobin below the first percentile. Specifically, at Intermountain Healthcare, which we have about 22 hospitals, we used 10 years of data looking at hemoglobin and hematocrit drawn within the first 6 hours after birth that fell below that bottom line, and found that those with the lowest values were typically those where hemorrhage was the cause, more commonly than hypoproduction, mixed causes, hemolysis, or an indeterminate cause. Here's the evidence that we used to support whether anemia at birth was hemorrhagic from hemolysis or from hypoproduction, or whether we couldn't really determine it. For hemorrhagic anemia, we looked for evidence of blood loss into the mother's circulation with the Kleihauer-Betke or flow cytometry with antibody to hemoglobin F. We evaluated the possibility that these were twins with a twin-twin transfusion, had internal hemorrhage, fetal bleeding, any evidence of abruption or other perinatal event that would cause a blood loss. For hemolysis, our best test now, in looking at a baby with anemia and asking, is this hemolytic or not hemolytic, our best measure is the end-tidal carbon monoxide. Let me show you briefly how that works if you're not using it yet. This is a device that's basically a carbon monoxide sensor that's attached to the baby through a nasal cannula, a soft silastic cannula. And it measures carbon monoxide, which is relevant to the issue of hemolysis, because every molecule of heme that is degraded to biliverdin and then bilirubin, every molecule releases a molecule of CO, which as a gas eventually finds its way to the lungs and is exhaled. And therefore, measuring end-tidal breath carbon monoxide minus any CO in the ambient gas, which is measured and subtracted out of the equation, gives us a metric that from which we can figure the lifespan of the red cells. Other ways that we can measure hemolysis or assess it, of course, we've got maternal and neonatal blood types, Coombs test, carboxyhemoglobin, which is the same principle of end-tidal CO, but not quite as sensitive as end-tidal CO. Haptoglobin levels fall with hemolysis. Hemoglobin appears free in the urine with hemolysis. Blood film examinations give us some indication, and then looking for the exact mutations that cause some of our red cell cytoskeletal and enzymatic defects. Of course, we use enzymatic panels or genetic panels. For hypoproduction, a rare cause of neonatal severe anemia at birth, careful dysmorphological examination, genetic panels, iron studies, because we can't forget that iron deficiency can occur at birth, particularly if the mother is profoundly iron deficient herself. And so iron studies like retic, hemoglobin, micro-R, and hypo-HE can be quite helpful, as can serum erythropoietins. So anyway, look at these three columns. These are babies that all had severe anemia at birth. The first column are babies whose hemoglobin fell just barely below the first percentile line, less than a gram per deciliter below the first percentile. And then these various shades tell us the probable cause as best we could determine from the medical record. When the anemia, although severe, was only borderline severe, most of the time there wasn't enough laboratory tests drawn to really figure it out. That's what the white area is. This next column shows the breakdown of the causes when the hemoglobin level was even lower, that is 1 to 2 grams below that first percentile line. Less of them were unable to be determined, more of them were hemorrhagic. And then the most severe, those who were more than 2 grams per deciliter below the first percentile, the greatest percentage of those were hemorrhagic. Here's one subset of that group, and that is with placental abruption, anemia does sometimes occur. Now, this is a paper that we put out in Journal of Perinatology last June, a year ago, because there have been questions in my mind and the mind of others about how frequently does severe neonatal anemia occur because of abruption, or does it ever? Because that's mostly, if not entirely, maternal blood that is lost in an abruption. So what I'm showing you here is from that paper, and there are two panels that are just one on top of the other, just very much like the ones I showed you with gestational age here and hemoglobin here. The upper panel is 564 neonates born after a confirmed placental abruption, confirmed by the obstetrician or the pathologist or both, who had one or more hemoglobins recorded during the first 24 hours after birth. Notice that several of them fall down here below the first percentile line, with hardly any above the 95th percentile line. It looks like the whole thing is just pulled down a little bit. If you look below the 5th percentile line, about 25% of all the babies are below the 5th percentile. Now, panel B is a subset of the upper panel. And what this is, there were 286 neonates born after what the pathologist or obstetrician are both called as a small abruption. They specifically mentioned either small or just on the margin. And when we plotted those on the same chart, it was a much more normal distribution. Only one really fell down here with severe anemia, and these two fell in the polycythemic range. So here's what I conclude from that study. Neonatal anemia is expected after 15 to 20% of maternal abruptions. And unless the delivering clinician documents and swears to you that the abruption is really small or marginal, and unless the neonate appears to you to be completely well with no signs of hypovolemia, then I think it's up to us to surveil for the possibility of significant fetal blood loss as a routine step instituted in the hours after birth if there is a severe abruption. Most of them won't have anemia, some of them will, and maybe 16% will be severe. Another form of severe neonatal anemia, one of our more common, was in fetal to maternal hemorrhage. This is a paper we published 2 years ago in Transfusion, where we looked at 300,000 live births, found 42 of them with anemia at birth that was clearly from fetal-maternal hemorrhage. And here I'm going to be focusing on the nucleated red blood cell count, and then I will use this slide to transition to review something about nucleated red blood cell counts. We found something here that I thought was worth telling and quite curious. And that's that when we could determine by the maternal history that the fetal maternal hemorrhage occurred recently, like within a day, because the mother was in an auto accident or fell down the stairs or had a blow to the abdomen or something like that, those babies had normal nucleated red blood cell counts at birth, even though all of these babies had evidence of fetal maternal hemorrhage, sometimes really severe. But even really severe ones with a maternal auto accident, if it was recent, their nucleated red blood cell counts were normal. But the nucleated red blood cell counts were elevated and I'll show you what elevated means in a minute, if there was evidence that this hemorrhage occurred more than a day, more like 2 or 3 days before birth. I'll get back to that, as now we're going to be talking about nucleated red blood cells and how that can help orient you to the anemic neonate and the neonate with encephalopathy. So here is a nucleated red blood cell. It's barely starting to produce hemoglobin, which is why it's a little bit pink. There's still a lot of nucleic acid, organelles and such, which is why it's blue. But then the distinctive feature is the large nucleus within it. It's very abnormal to see any nucleated red blood cells in the blood smear of an older child or an adult. If you're looking through his blood smear and you find one, it should pique your interest as to something is wrong. But you see them in preterm neonates. You even see some sometimes in term neonates. And so we ask the question, what is the normal range? What is the reference interval for nucleated red blood cells according to gestational age? The other question I want to ask and answer is, how long does it take between the time a fetus experiences a hypoxic event, like fetal maternal hemorrhage or something like that, and the emergence of those nucleated red blood cells in the fetal circulation? Something that you could call the emergence time. How long does it take? Does it happen instantly after hypoxia, or does it take some period of time? Okay, let me see now. All right, so here what you see are nucleated red blood cell count nomograms in neonates. Again, there's an A and a B panel. The A panel are nucleated red cells per microliter of blood, and the B panel is nucleated red cells per 100 white blood cells. I don't know how your lab likes to present it. Maybe one way, maybe the other, maybe both. But panel A is nucleated red cells per microliter. Panel B is nucleated red cells per 100 white cells. And here is the gestational age in weeks and the counts. And looking at the upper panel first, you see that the 5th percentile drags right along 0. So here we have babies that are 36 weeks to 40 weeks, and it is perfectly normal for them to have none. And that is seen in a great percentage of cases. The average is about 1,000 per microliter. The upper reference interval is somewhere around 3,000 per microliter. Above 3,000 per microliter is elevated. Now, the same principles apply to this one, which is nucleated red cells per 100 white cells. And the 0 nucleated red cells is perfectly normal. On average, they have maybe 6 or 7, with an upper reference interval of perhaps 13 or 14. So above 13 or 14 is above the 95th percentile, hence abnormally elevated. A high nucleated red blood cell count has been in the literature for decades as a potential biomarker for fetal hypoxia. But it's unclear whether a high nucleated red blood cell count indicates acute hypoxia, something that just occurred a few minutes before delivery, or exclusively indicates more chronic hypoxia, something that started many, many hours or even days before birth. So, how long does it take between the onset of severe fetal hypoxia and the appearance of nucleated red cells in the blood? There have been several publications on this. The first one 20 years ago didn't provide any experimental evidence, but did state acute stress can cause immediate nucleated red cell release from the bone marrow. However, the animal experiments that followed this over the next decades could not find that at all. In the rat models, it took at least 24 hours between the time the dam was made hypoxia, the pregnant rat, and the appearance of nucleated red cells in the hysterotomized fetal rats. Also, clinical studies where erythropoietin is administered to a neonate, and you look to see they had no nucleated red cells before. Do they afterwards? And if so, how long did it take? And it never happens immediately. The average is more than 24 hours lead time. So I'm going to end this segment by some sheep studies that try to measure the nucleated red blood cell emergence time after fetal hypoxia. These first studies were done by Jack Widnes in Iowa. After producing in utero fetal hypoxia, it takes 4 to 5 hours before the fetus starts increasing erythropoietin gene transcription and production of EPO to the point where the blood level elevates. After the EPO goes up following hypoxia, how long does it take before nucleated red cells appear in the blood? This is a study that follows Jack Widnes' study to answer that. Here are two panels, nucleated red cells per microliter and nucleated red cells per 100 white blood cells. And in each, you have two lines. There is a gray line and a black line. These are because the newborn sheep were injected with either high levels of darbepoetin or a vehicle control as a placebo. And so following the administration of the darbepoetin, which is long-acting erythropoietin, it took 24 hours before the nucleated red cell count started to go up, and it plateaued somewhere between 48 and 72 hours before it started to come back down. The same was true whether measured that way or nucleated red cells per 100 white cells. There was some statistically significant but small increase by 24 hours, but 48 and 72 hours is where it peaked. Consequence of all those studies, I would say that from animal studies, it takes 4 to 5 hours for a hypoxic fetus to make EPO to the point where it actually raises the fetal EPO level in the blood, plus another 24 hours or so to see the appearance of nucleated red cells in the fetal blood. Clinical observations in human neonates support this with several studies, and a high nucleated red cell count at birth then, I believe, suggests that fetal hypoxia occurred at least a day or two or three earlier. Now, this study also from 2 years ago looks at neonates in our multi-NICU healthcare system who were cooled for therapeutic hypothermia. So they all had evidence of moderate to severe encephalopathy. There were 152 of them in this particular study who had encephalopathy, who were cooled, and who had equal to or more than 3 nucleated red cell counts done in the first days, and who also had a thorough neurodevelopmental evaluation at about 2 years of age. Those that had a documented sentinel event during labor, so something acute happened, cord compression, uterine rupture, or something like that, virtually always had a normal nucleated red cell count at birth. So something that just happened within hours did not elevate the nucleated red blood cell count. And when that was the case, even though they could be quite encephalopathic and very acidotic, if the nucleated red cell count was normal, within those limits that I showed you, their odds of surviving to discharge were 3-fold higher than if the nucleated red cell counts were elevated. And at 2-year follow-up, their odds of having no neurodevelopmental impairment were 6-fold higher than those who had high nucleated red blood cell counts at birth. So why, in a neonate with hypoxic ischemic encephalopathy, is a high nucleated red cell count at the time of birth a bad signal? I think it's because it identifies that that baby has had hypoxia that started well before birth, 1 day, 2 days, maybe 3 days. And maybe that's a little more difficult to recover from than a hypoxic event that just occurred a few hours before birth. Now we're going to move on to platelet transfusion refractoriness. Multiple NICU platelet transfusions. Maybe you already know this. I think this is fairly new, however. Multiple NICU platelet transfusions almost invariably generate severe chronic lung disease. And we've done two large retrospective analyses published in 2009 and then again last year, looking at different epochs in our healthcare hospitals, showing that all neonates that got 20 or more platelet transfusions developed BPD, and all developed a period of transfusion refractoriness. I'll get into that in a minute. All of them, in both of these studies, all of them either died from respiratory failure or lived with a trach. Adult donor platelets that are transfused into neonates, it's a wrong paradigm. If we could avoid that, now sometimes we can't, but if we could avoid that, we're avoiding putting pro-inflammatory cells into a baby who probably already has some degree of lung damage. Excuse me. Because adult platelets have much more pro-inflammatory markers and cytokines and activity than does the comparable platelets of a fetus or neonate. Both red blood cell and platelet transfusions worsen pulmonary inflammation in neonates. This is a paper that we put out last year where we tried to define what refractoriness was. And we settled on this with this considerable evidence base, and that is that when you give a platelet transfusion of 10 ml per kilo of apheresis obtained platelets, and that fails to increase the platelet count by 5,000 per microliter, we're labeling that as a refractory state. When your patient develops refractoriness to platelet transfusion, it generally sets up a vicious cycle where you give a platelet transfusion, it doesn't seem to do much, so you order a second one. And it doesn't seem to do much, so you order a third. And some of these babies can have platelet transfusions every day for many days or weeks, and suddenly they're up to the 15 to 20 platelet transfusion limit, and they tend to have terribly severe lung disease. If you have a baby that has developed platelet transfusion refractoriness, here's what we are advising. And on the basis of a large retrospective study that gave us this information, we're suggesting that you lower the threshold a little bit. If your threshold is 25,000 per microliter and the platelet transfusion is given because the count was 20 and it only went up to 22, we're suggesting that you just consider lowering your threshold a little bit. Maybe not 25, but maybe 20 or maybe 15. Unless the baby's bleeding, try your best not to keep giving platelets that don't work. Second, if you look at this paper, you'll see there's evidence that if you're transfusing ABO identical platelets, you're likely to get a greater increase in your increment than if you're using ABO mismatched platelets. I don't really know how it works in Australia, but in the United States, we rarely pay attention to the ABO compatibility between the donor platelets and the recipient's platelets. But our blood bank will work with us on this. If we have a baby that's refractory and we want to give them more platelets, we're asking for ABO identical and they're giving them to us when they possibly can. The other thing we've looked at is the how old the platelets are. That is, how long have they sat in the blood bank? Depending upon the type of safety measure you apply, whether it's a radiation or intercept process for pathogen reduction, those platelets are going to be outdated in 5 days, maybe 7 days under some circumstances. And if you have a baby with platelet transfusion refractoriness, our blood bank will supply us not the oldest platelets they have, but the freshest platelets they have. Usually the management of the blood bank depends upon giving us the oldest platelets, those about ready to outdate, so as to manage their inventory wisely. But if we have a baby that is in need of a transfusion and the transfusions are doing very little, we're asking for the very freshest platelets in the blood bank, and they're giving them to us. And there we're seeing an additional increment of 15 to 20,000 per microliter for every 10 ml. Now I'm going to go to donor sex and age. So which volunteer blood donor group by sex and age is the best donor group to donate blood for our NICU patients? Do we want old guys, young women, or old women? Well, there are two recent publications on this, but unfortunately they came to opposite conclusions. In 2018 from Brown, their study reported 63 preterm neonates that received transfusions only from male donors, and those lucky babies were twice as likely to survive without any major morbidities. And so the call came out at that time, let's be looking at male donors. They didn't look at age. I don't know if it's older males or younger males, but male donors were better donors for our NICUs than female donors. Well, a couple of years after that, from Emory, a similarly small size study, 56 preterm neonates received blood only from female donors. And those lucky babies that got blood only from females, were twice as likely to survive without major morbidity. And not only that, but the grandma blood was way better than the teenage girl blood. So the Brown study said you want male donors. The female donors are not so good. However, the Emory study said just the opposite. You don't want male donors, you want female donors, and the older, the better. At that time, we thought this question is so potentially important, but with two discordant results like that, this calls for a very large data set. So we gathered the data from 15 of our hospitals, looking not at 50 or 60 transfusions, but 13,000 transfusions, and not just red cells, but looking at all of the products separately. And this was done in a way that we knew the outcomes before we got from the blood supplier the sex or the age of the donor. So we had all the outcomes in our database. We then plugged in the donor sex and the age, and here's what we got. These are the outcomes. Death occurred in 18% of those that got females' blood only, compared to 18% of those that got male blood only. No difference. Severe BPD was the same, whether they got boy blood or girl blood. Severe to moderate neck, retinopathy, composite scores, they were all the same. And so we think the preponderance of evidence supports the practice of transfusing our NICU babies without much concern about the donor sex or the donor age. The month after we published that in Blood, there was another huge study in the New England Journal with a similar specific aim, but a different study group. These were adult patients receiving transfusion. This is from the Montreal group that showed, just like ours, that donor sex and age did not have any effect on mortality of the transfusion recipients. So now we'll go to the last issue, and that is explaining the advantages of a low titer type O whole blood for acute perinatal blood loss, and using term cord blood as a transfusion product for extremely low gestational age babies. For pulmonary hemorrhage and NICU hemorrhage, What we have always done is to use component transfusions. If it's a severe massive hemorrhage, we will give packed cells, platelets, and plasma, sometimes cryoprecipitate too, if the fibrinogen is low, in sequence. There's a better way. That way was looked at initially with the US military in far forward battle situations where sequential transfusions of components was not nearly as timely or as efficacious as using whole blood. And in the journal Transfusion in March of 2019, there were articles about the military use of whole blood and other articles about the civilian trauma service use of whole blood. But it was a specific kind of whole blood. Now, whole blood transfusions is the way transfusion medicine began back in the World War I area on the battlefield. But since Vietnam, component transfusions have eclipsed, totally taken the place of whole blood transfusions for massive military hemorrhage. Then the military developed, with the Gulf Wars, a whole blood product. And this whole blood product was non-cross-match. It's Group O. It's whole blood. It's stored in the refrigerator and given through a point of care warmer. And the military data is very convincing that it is a better treatment than serial components. This is blood type O with low titers of anti-A and anti-B. Why? Because you're giving this sometimes, most of the time, without knowing the blood type of the recipient. And about if you're giving type O to a type A recipient, that type O blood may have very high titers of anti-A that could hemolyze some of the recipient's red cells. So this particular military product is using only type O blood that is from a patient where the anti-A and the anti-B titers have been measured and found to be safely low. It is fully tested. It is CMV safe by leukoreduction using a platelet-sparing leukoreduction filter. It's stored at refrigerator temperatures up to 14 days. Some trauma services are now holding it up to 21 days, but we're holding it up to only 14 days. But if it's not transfused, it's not wasted, because at that time it is made into a red cell product and a plasma product and put back into the inventory of the blood bank. We're using type O RHD positive if we know the female is Rh positive, and we're using it for all males. We're using Rh negative whole blood if the female recipient, the mother, for instance, is known to be Rh negative, or the neonate is already typed and known to be Rh negative, or if it's a female where we don't know the blood type, then on the safe side, we're giving O negative. And we have both in the inventory at all times in all of our major hospitals. It's transfused by a blood warmer because it's cold, but using a inline blood warmer, it's a physiologic temperature when it enters the patient. It hastens the synergistic effects of giving plasma, platelets, and erythrocytes by giving them all together because they interact. And it causes a more rapid cessation of bleeding and a more rapid correction of coagulopathies with less volume overload, because it actually is in less volume because you don't have to anticoagulate each component. So this thing that started as military blood, and we sometimes still call military blood, we're going to give that to babies? Yes, indeed we are. The first one we used was 2022 for a baby with acute massive hemorrhage. We've done a series since, and it is now it's now our standard treatment for acute blood loss. Also for military blood for moms, whether they're military moms or civilian moms, if they have postpartum hemorrhage. The first such woman to receive type O low titer blood was in 2019, but Now, many centers, I don't know about Australia, but many centers in the United States are using this product, not component therapy, for acute blood loss in postpartum hemorrhage. Now, I'm going to end with this. This is something that we're not doing. Well, we're well into these studies, and so are some other centers. But just for your information, that we're calling this program the UBET program. That stands for Umbilical Cord Blood for Extremely Low Gestational Age Transfusions. It's a collaborative effort between the Intermountain Healthcare Hospitals, the American Red Cross, and the University of Utah. Here's a schematic as to what we're trying to accomplish here. Healthy term babies, after they have delayed cord clamping and the cord is severed, as you see here, and clamped, there's still blood left within the umbilical cord and placenta, fetal blood, that can be removed using the Red Cross donor draw equipment in an aseptic fashion, sterilely inoculating that blood into a Red Cross donor CPDA containing bag that is then sent to the Red Cross cord blood center a few blocks away from the hospital, processed and tested and made into a transfusion product, which is sent back to the hospital to study as a transfusion product for our smallest babies. Well, why go to all that trouble when we've already got plenty of adult donor blood available to meet the needs of our anemic, extremely low birth weight neonates? Some of the differences between adult blood and fetal blood are shown here and form part of the reason why we think this is a better product. Adult blood, as you know, is 96% hemoglobin A, which is very different in the way it releases oxygen to the tissues compared to hemoglobin F, which is more than 80% of the hemoglobin in the fetal blood, in the cord bloods that we're drawing. Adult blood releases, adult hemoglobin releases oxygen to those tissues much more abundantly than does fetal hemoglobin, which binds it and releases oxygen in a more sparing fashion to the fetal tissues. And it could be that some of the disorders of our extremely low birth weight neonates, like retinopathy of prematurity and BPD, are oxygen toxicity issues, in part perhaps related to the fact that they're full of adult hemoglobin, which is giving their lungs and their eyes more oxygen than it really should have. Also, the red cell cytoskeleton of adult red cells is much more rigid than are those of the fetal red cells, which is more flexible. And inflammatory markers are much more present in the presence of transfused adult blood than in transfused fetal blood. So here are 3 papers, all showing the same thing, 2 from Rome, 1 from Hopkins, all within the last 2 years, that for the tiniest babies, the more times you transfuse them with adult blood, the higher their adult hemoglobin levels are going to be. That's obvious, but the higher their ROP incidence is going to be. Well, we're concerned about ROP, but we're also concerned in our extremely low birth weight babies about the high incidence of severe BPD, necrotizing enterocolitis, brain hemorrhages, neurological issues, a lot of things other than ROP. In fact, here are some papers from our group and others showing an association between platelet transfusions, red cell transfusions, and the incidence of BPD, between transfusions and ROP, between transfusions and IVH, and between transfusions and NIC. So a few months ago, we published this first in a series of studies looking at the possibility of making term neonates, otherwise discarded blood, the product of choice for neonatal transfusions of our smallest babies. It was a retrospective analysis of all of the transfusions given to LGANs in our group of hospitals the past 3 years, estimating the amount of blood that we would need if we changed the paradigm from adult blood donors to umbilical cord donors. We assessed the interest in the product, and we assessed implementation barriers through stakeholder surveys, and found that basically the bottom line is that if we could successfully draw blood, even 50 milliliters as a minimum, of otherwise discarded blood from only 10% of our term healthy deliveries would have 4 times more blood than we need to supply the transfusion needs of all of our LGANs in all of our Intermountain Healthcare hospitals. So that study is done and it's out in the Journal of Perinatalology. We're just finishing up this last week, the step 2, and that is how much blood can we actually draw? Okay, I don't have those pictures to show you, but sometimes we get the placenta when it has been delivered. Then we basically hang it on a stand and gravity drain the blood into a Red Cross donor bag sterilely. Other times we are able to get the cord blood drawn when the placenta is still in utero in the 3rd stage of labor before the placenta is expelled. We get almost twice as much blood that way. Then step 3 is one for which we're now just in the process of designing and seeking funding, and that is to send this blood that we draw to the Red Cross, have them do all of the FDA mandated testing and preparatory steps so we have a Red Cross approved blood product for platelets and another Red Cross approved blood product for packed cells where the source is fetal blood, not adult blood. And then we'll never know if this is a good idea or not unless we reach step 4. And that is we've got a product that's approved for transfusion, but does it do any good? And here we'll have to design a multi-centered trial where extremely low gestational age neonates will have their transfusion needs met randomly by either getting their transfusions from adult donor source or fetal donor source. Then we'll know. So just to sum up quickly, we've talked about evidence-based definitions for anemia in the neonate, how looking at nucleated red cells can help you. No effect of donor sex or age on transfused outcomes, which is good news to me. That there is platelet transfusion refractoriness out there in your NICU, but you can deal with it. And low titer type O blood for acute blood loss, and the possibility of UBED on the future of NICU transfusions. And I know that's a full hour. Thank you very much for your kind attention.
No, thank you, Professor Christensen. Bob, this was a great summary. And as you said, you wanted to give us some useful information, which we can already explore. And I've made a little list of at least 2 things which I definitely want to